Then there is also Dr. Pratinderaj Onta. I think he's also from Nepal. So we had a lot of nice bonhomie, and we used to have a lot of parties in Korea. So we used to have food together, attend cases together. So it was very, very nice. And I'll start off, and thank you so much. Can you enable my screen sharing, Vivek? Because it is not enabled.
Now it is enabled.
Yeah.
Great. We can see you.
Yes. I'll start with the proximal humerus fractures. So the proximal humerus fractures is one of the most common fractures in the shoulder, and also in entire orthopedics. It comes around 5.7 or 6% of the entire fracture series, and it is done by all of us. All of us do the proximal humerus fracture, and with our experience, every surgeon would have his own individual identity or technique of doing this proximal humerus. Proximal humerus is very important because of the complications involved, especially highly mobile joint. There are a lot of problems like avascular necrosis, secondary osteoarthritis, and mostly the stiffness. Even if you fix it properly, you can have a lot of stiffness. So definitely a very demanding fracture. I'll briefly go into the different aspects of the proximal humerus, and also some literature which I felt was important and which helps in our decision making. So again, I was saying it is around 6%, and it is the third most common of all osteoporotic fractures. If you look at the above 65 years, 64 years group, it is like the third most common. And again, in the older age group, it is more common. And definitely, we can do lot of non-operative treatment. 85% of this goes in for non-operative management. Yeah. When we look at the surgical anatomy, I felt the most important thing is the vascularity. So, which remaining, we know about the cuff. The cuff has to be fixed properly. We have to take sutures in the cuff. But protecting the vascularity is the key. When you look at the vascularity, 64% to 65% of the vascularity comes from the posterior circumflex humeral. So here, if you look at the surgical anatomy, when we are dissecting it, so the lower part of the subscapularis, that is where the divisions happen, the posterior anti-circumflex humeral. To the quadrangular space, it goes behind, and then it comes in, there are ascending branches which actually goes up the posterior circumflex humeral. We know the anterior circumflex humeral is also important because whenever we position the plate, we position it at least 1 centimeter away from the bicipital groove, again because of the arcuate ascending branch of the anterior circumflex humeral. So protecting this is the key to having a great recovery or healing. So all of us know about the classification. I will not delve into details of the classification, but the most important takeaway from the classification is that higher the fracture pattern, that is worse the fracture pattern, with like 3, 4, or even in the AO group, the worse the results. Let it be complications or healing rates, worse the results. So now, imaging, the trauma series AP, scapula Y axillary. But I would say that intraoperatively, or even getting an idea about the posterior fragments, the Valpew axial review, this one would really help, where the patient leans back and we can take a shot like that. So it gives an idea about the posterior, not only the posterior glenoid and as well as the posterior fragments. Even a GT, we can find out where exactly the posterior fragment, because most of the GTs get pulled up posterior-superiorly. Then again, the CT is important, and the MRI. So I'll come into the specifics of the X-rays a little more later. But when we look at after the X-rays, we have got the X-rays done. When we look at the treatment algorithm, I felt that there are a few simple takeaways. One is less than 50 years, always fix. Let it be a head splitting fracture or let it be a fracture dislocation, whatever it is, we need to have whatever possible reconstruction we can have, we should have it. If it fails, we can deal with it, but definitely it should be fixed. Even if it fails, we have a good bone stock to build on to a replacement later. At the same time, now there is also this concept that if you are less than 50 years, and if, for example, if it is a completely non-reconstructible, completely comminuted fracture, so there is no point in saving it. So we can do a hemi replacement. So I'm repeating it, less than 50 years. If we can't salvage it, if it is a non-union or neglected case or a neglected fracture dislocation case, or if it is completely comminuted, we can do a hemi replacement. There are processes in India. I commonly use the evolutus. So we have a provision where we can convert into a reverse later. So that is one of the important takeaways. More than 50 years, again, undisplaced conservative, displaced is fixed, head splitting fracture dislocations, you can do arthroplasty. So if the patient is earlier, the dictum of the reverse was like about 65 years. But even now, okay, above 50 years, we are doing reverses. So if you know that there's a non-union case, neglected case, head splitting case, and the patient is even between 50 to 70 years of age, definitely we can do a reverse. Then suppose the patient is above 70 years and the patient's function is good. That means he's quite active and his function is pretty good. Then we can do a reverse. At the same time, he's got a lot of comorbidities and his functional requirement is not much. Then we can go for a hemi. Coming to conservative management. So all stable, undisplaced fracture we can conservatively manage. But there have been papers, when we look at literature, we can see even minimally displaced fractures. That means not completely undisplaced, but minimally displaced fracture. They have also been treated conservatively. What are the outcome rates? So the first slide of mine was that 85% of the proximal humerus fractures are treated conservatively. So now when you look at it, yes, the results are pretty good across the fracture patterns. The results depend upon the age and the degree of the fracture displacement. The main complications even seen in a proximal humerus conservative management are pseudoarthrosis, malunion, AVN, and post-traumatic arthrosis. Next, from this, let us go to the next step, which is basically the operative, that is a percutaneous spinning. Suppose it is displaced and the proper displacement more than 45 degrees, more than 1 centimeters, valgus impacted, isolated surgical neck can be treated percutaneously. In my practice, I very minimally do this, very less I do the percutaneous spinning. I do this only when the patient is not fit for surgery or doesn't stand for long hours of surgery. So I can do under block and get out of it. And especially on older patients, less of demand and undisplaced or minimally displaced fractures, I do it. So why is that I shy away from percutaneous fixation? Because I find that in my practice, I find that I do have delayed unions, malunions, non-unions, and also pin migrations. So never in my practice, okay, I didn't have a great experience with percutaneous spinning, but it is definitely something which we can use in minimally displaced fractures and where the demand is less and in older patients. But again, the most important problem is even the percutaneous spinning, one of the important criteria is we need good bone stock should be there. So older patients again are osteoporotic, so lesser fixation. So that is again a problem there. So these are my takes on the percutaneous spinning. So then coming to principles of pinning, there are certain principles when you look at the literature. So there is a certain way of, I suppose this is a proximal part. You can see the X is where the curve of the proximal humerus is coming down like this at this particular point. Double of that should be the distal pin entry, and it should crisscross like this. The spacing should be 2 centimeters. So these are the some of the principles in percutaneous spinning. And along with percutaneous spinning, we can also do a percutaneous reduction. So percutaneous reductions are, we can use a deltoid split. We can go above the axillary nerve area as well as below the axillary nerve area, leaving that margin of the 2 centimeter there. So this is a very interesting technique. We can, that is, you can see this, okay, with a blunt instrument, you can actually reduce it and hold this with a pin and fix it with screws. So we can also, for example, if it is a displaced GT, we can like this. Again, we can do percutaneous is not possible. You need to open it, reduce it, take a suture, and then fix it with wires as well, like this. This is also a great technique. Now, what are the outcome rates of the percutaneous fixation? This also has its set of complications and problems. Osteonecrosis, 26%. Post-traumatic arthrosis. Interestingly, interestingly, it is around the osteonecrosis seen 50 months later after percutaneous fixation. That's very, very interesting. That means the wait is quite long. And the highest rate of AVN when you're doing percutaneous pinning is what with 4-part fractures. Then coming to the next invasive is your trans-osseous fixation, where there is a method of suturing. Sutures are taken through the GT, LT, and the proximal humerus, and we can fix it. So this, we can fix it with, for any kind of fracture pattern, like a 3-part, 4-part, valgus impacted, we can fix it. But it is contraindicated for a 2-part surgical neck because you don't get the stability. And the results are pretty promising in this as well. Again, I don't do this. Coming to the proximal humerus, intermedullary nailing. So now, when you, what is the latest in the nail we have? The latest 3rd generation nails are straight nails. That means curvatures are not there. And they go directly on top of the humeral head like this. Earlier, the entry point was in the red, but now it is here in the blue. Why? Because this has got a better bone stock compared to the GT area, better bone stock, and direct entry into the canal. So very useful for pathological 3-part fractures, pathological fractures, and fractures with humerals extension into diaphysis. So another important thing about this particular nails is the synthesis nails. They have kind of holes through which you can see this holes here, and which can be buried into the bone. But the important thing is we can pass sutures through that. So again, we can actually hold up when we're using this. So coming to the next, which is the most commonly done, the proximal humerus plating. So here, the plate is an excellent device. But before plating, we know about the Hertel's criteria, which is basically the metaphysis, metaphyseal extension of the calcareous, if it is less than 8 mm, and if there is loss of the medial hinge, and if it is an anatomical neck fracture, higher incidence of AVN. So, but there have been modification to the Hertel's criteria. Along with the fracture patterns, other than number of fracture pattern or the AO classification has also been added on. There's a paper by Lambert which speak about this particular thing. But overall, to say that we can go by this and gives an excellent idea to the outcome of our plating. So now I will not go into the details of plating because all of us plate. So what I would try to say a few things which I feel is important, and one is varus reduction is not acceptable. You should have it in a valgus reduction. A preoperative is another important thing. A preoperative varus shows that this can result in collapse later. That is another important thing. A calca screw, see, the most important screw is the calca screw. It definitely reduce the risk of a varus collapse. Then another important thing is after we do the reduction, we have done the reduction, we always see the posteromedial comminution. The posteromedial comminution is the key. We have to check for the posteromedial comminution noted in the X-ray as well as in the CT scan. We should always graft it if we find a posteromedial comminution. Grafting can be an iliac crest corticocancellous graft or even a fibula stud graft. Then what we know is that sometimes this is extremely osteoporotic in especially my part of the country in India, because we find a lot of osteoporosis. And we find that the head is just a shell. And again, screw penetration is a problem. Even though, okay, even if you have a perfect X-ray, after maybe 2-3 months, you can see that the screw is just cut out. So now, earlier, the thing was, the things all of us do is that we just make a small entry or just put the screw. We don't drill it even through up to the subchondral bone. That's one thing we don't do. So you just put the screw just like that is something we do. So earlier, the principles were like, go maximum up to the subchondral bone because we have quite a bit of bone stock there. Remaining everything is a shell. Going up to the subchondral bone is a good idea. But still, we have screw penetration. So for this, we have new techniques like cement augmentation. We can inject cement and then put the screw so that this will not cut out. Again, it's an excellent technique. Only problem is, which is documented, is that you can have necrosis because of the extreme heat. There are other options also, like calcium phosphate and calcium sulfate. Calcium phosphate, phosphate paste, calcium sulfate paste are available. So where it is injected, and especially the calcium phosphate has good properties. The thing is, if you use calcium sulfate, there are chances of inflammation, and you can have a continuous serous discharge there. Especially in fractures, we can have a discharge. But calcium phosphate, there is apparently no discharge, and excellent osteoconduction, and the penetration is almost nil. It's supposed to be these are the 3 different augmentation techniques which are possible. I've done with cement augmentation, the phosphate and the sulfate. I have not done. The availability of India is also doubtful. Coming to the reduction tips, there are minimally invasive techniques as well as, so normally we go to deltopectoral approach, open it up. We can also do 2 incision technique, that is proximally deltoid splitting. For example, this is a 2-part surgical. We can make a minimally invasive 2 incision up, that is 1 incision up, like a MIPO, reduce it like this, and open again 2 centimeters after the skin bridge of the axillary nerve, and fix it like this. And in 3-part also we can do that. These are excellent techniques of reduction. So another thing which I utilize in my reductions are the steam and pins and indirect reductions. I don't try to expose too much of the fracture at all. Sometimes it is just basically a bag of bones with a lot of muscles around. So my main thing is the sutures through the muscles, and the transverse sutures which help me in the reduction. And the important thing which can help us in our armamentarium, especially in these kind of post-medial communication, we have comminution, metatarsal fracture extension, non-unions, are the fibula stud graft. Coming to the stud graft, so you take it like about 10 centimeters away from the ankle, so that ankle stability is not a problem. And one edge can be put into the canal, and the other can be impacted up. And again, biomechanically, this is supposed to be very good. It's supposed to give excellent fixation, at least it holds up well, doesn't go into varus. So these are the biomechanical properties which we see with the fibula stud graft. And this, all of us know about the complications of plating, varus, screw cut out. I'll come to the salvage later. This is something important I mentioned earlier, that how the bone cement or the calcium phosphate and sulfate can also help in augmentation and prevent screw penetration and better healing. Coming to the next thing which we can do, coming to the hemiarthroplasty. My indication for a hemiar, any patient who is like more than 70 years old, one who can't afford a reverse, so even if in a little younger patient, or even if the patient is above 70 years of age, functionally high demand patient, functionally very, very strong patient, very motivated patient. Very motivation means should be able to do a rehab process very well. So those kind of patients definitely I would have gone in for a reverse, but who are not so motivated, functional demand is less. And in those kind of patients, definitely comminuted 4-part anatomical neck fractures, head splitting fractures, non-unions, failed internal fixations, all these patients, definitely I will do a hemiarthroplasty. Coming to the hemi, these are the, I'm not going to detail of this, but we know that the center of the head is slightly posterior and medial, the posterior-medial offset is there. And another important thing is we would like to have something to remember, at least 10 millimeters from the tip of acromion to the head. So these are the, and another important thing is the GT should be always level. That means it should be at least 10 mm below the head. Otherwise, it can cause impingement. These are the, so you can do, just to have an offhand number, 10 mm here and 10 mm below. This space should be 10 mm and this should be at least 10 mm below. These are the principles we should keep in mind when we're doing it. So the surgical considerations, the surgical technique as such, I will, the different slides I'll show in the reverse page. But here in India, we have a local Indian processes, which is extremely inexpensive. Actually, it's like basically around 10,000 rupees or 7,000 rupees. We have one particular implant. So again, it is a simulated implant. It is a bi-modulator, there are 3 modulation in that. And we can adjust the versions, or it is in a single thing, but we can, there is some variability what we have there. But surgically, what are the things which you should keep in mind when we are doing a hemi? Yes, one. So what is the approach for a hemi which I use? Always a deltopectoral approach. Because for me, the taking the bites, the reductions and all that, I find it very, very comfortable. And again, my training was like that. So I am able to do in a deltopectoral. So in a deltopectoral, the first thing is when we go inside, we identify the conjoint tendon and go to the lateral aspect, see the biceps, so find out, go along the biceps and you can go into the joint. So I cut off the biceps that, take a stitch that so that I can do a tenodesis later. Then the next thing I do is I isolate the subscap, that is a LT fragment is quite big. I'll take a bite there. I'll take at least 3 sutures there. From up, middle, and the lower portion, I'll take 3 sutures. Then I go to the GT. If GT is not completely, I don't want it too much of a big chunk, but maybe like I would like a chunk of like around 1.5, 2 centimeters thick a chunk I would like to have in the GT as well. So if I'm not getting, if the chunk is, that is the fragment is very big, then I would osteotomize it or take a osteotome and cut it so that I can have an appropriate fragment. I usually take ethibond bites, number 5 ethibond bites I usually take in, again, 3 sutures there in the supraspinatus, infraspinatus area. Sorry. The remaining of the head is normally separable. Normally you can take it out. Or I would just take a osteotome cut at the articular surface level and take it off. Next, next process would be to actually make an entry with a entry reamer, which will go easily into the canal. And you do it for the different sizes which come 1, 2, 3, 4 goes according to the millimeter size. And whichever we don't have, because see, when we do a reverse, the purchase is in the friction of the purchase is in the proximal part, the GT area. Lower down the canal is quite wide, especially if you look at osteoporotic fractures in the older age group. So you're not looking for a tight fit there. So it has to just, you need to have a slightly stuck fit, it should move easily. And then the most important part is getting the retroversion. So now, because what happens is if you are doing, let us talk about a reverse in a regular case, like a cuff tear arthropathy case. In a cuff tear arthropathy case, I just have to do keep around 10 degrees or 20 degrees, maximum 20, or sometimes even 0 retroversion is okay. Again, retroversion, you can decide upon the opposite joint, but in fractures, it is ideal to keep it at 30 degrees because the soft tissue laxity is more. Because already it is fractured, the soft tissue, especially the GTLT, is already stretched out. And in those kind of cases, you want it a little more constrained by the version element. So it at 30 degrees. Then how do we keep it 30 degrees? We have instrumentation, which we can, I'll show that in the later pictures and in the video, how this is kept. So we have a jig which actually points it. We can adjust it 20, 30 degrees. It will point along the elbow and we can actually maintain the angle. Now, there are, if you can't, there is other way of, suppose you don't have a jig. And we have this, for example, when I had to use this particular Indian implant, then you have to take the epicondyles and keep it accordingly retroverted. So that is another way of doing it. But ideally, the jig is the best way to do it so that there is no, you don't have to go entirely by a lot of eyeballing. Then another important thing, GT should be 10 mm below. The tuberosities should be very well, reconstructed. I mean, you need to really, there's a technique of doing it. You need to pull it up and stitch it up together, because the function of a hemi entirely depends upon the cuff. So getting a subsequent chunk of the LT and the GT is very important. Suturing them back onto the process is very important. So we have fracture stems where the distal part is smooth, that is, it's for cementing. Proximal portion is for, like it would be coated for bone integration. It could be trabecular metal, different types come. So it could be coated, and we have holes for fixing it up. This reduction is very, very important, and we should take our time to reduce it, fix it. And I normally use SS wires to take the sutures and put it up tightly. I don't entirely go by, because especially the ethibonds, I don't think work very well in bone chunks. So I go by the old school of taking the SS wires. I find it good to do it. Again, that's what I said, overstuffing of the joint, having too much of bone that will affect your movement. And another thing is, this is the last part, which I said, that the space between the acromion and the head should be maintained. This is a tuberosity fixation technique. That means how we take it. So basically 3 sutures are passed to the GT, three sutures to the LT. The GT sutures, I'll keep it simple. We'll pass the GT sutures through the LT and come out. There are 3 in the GT and 3 in the LT area. 2 will be passing crisscross. And the remaining, we also pass through the humerus and do a figure of 8. So we can have different techniques. This is just one technique of doing it. So, but I make sure that it is very well, nicely covered and done. I do the same thing for a reverse as well. Reverse, for example, if it's a primary reverse for a fracture, then it is excellent. It is in failed cases, we don't get much of cuff and tendon to fix back. But here we definitely have, and a meticulous repair of this gives you excellent stability as well as mobility. So this is a fracture stem which I was talking about. You can see the proximal part is coated, and normally it is like 15 mm more than a regular stem, which is used in a reverse. Coming to functional outcomes, this is normally I tell the patient around 90 degrees. Most of the patients are older patients. But interestingly, I had a few patients who had to operate, young patients who had come with failed surgery, 2 times failed surgeries. The patient is only 35 years old. I didn't have any choice other than to do a hemi for him. He went on to do a good rehab. The rehab is the key here, because in the reverses and in in hemis, even if you are tying up the tuberosities, the most important thing is that we need the deltoid should be good. So the key, even for example, not in this regard, but even in regard to a cuff tear arthropathy case, I would say that how can we predict that such a patient will do well? If the patient deltoid strength is good, he will do well. So that rehab is also going to be deltoid-based rehab. So the same principle applies in reverse shoulder and in an SCR. There are different ways of activating the deltoid, the anterior, mid, and the posterior deltoid. And the Y, V, there are different techniques of in exercising them in prone position. And we make sure that the deltoid rehab has to go on very well. With that, we found that our patients are doing, this particular gentleman who we had done for this, that boy went to do like around 120 degrees, which was actually forward elevation, 120 degrees. Side was not great. He was like around 70, 80 degrees. External was also good. So that is one of the, these are the functional outcomes of the hemi. The complications are, as with all other arthroplasties. Here, I would like to highlight on the glenoid erosion. So glenoid erosion normally happens because of the version element. And it depends upon which part. If you're constraining anterior, then they start doing it. It'll start erosions posteriorly. Excessive glenoid retroversions can also cause problems. So that's what you see at the retroversion of 40 degrees is a problem. So it can end up in posterior wear out, one. Second, posterior dislocations. That is posterior base instabilities can happen. So 30 degrees is the key. We have to make sure that it is 30 degrees. Posterior glenoid impingements, proud process, that the processes are placed upwards, and tuberosity, non-unions, malunion, and proximal migrations. These are the different complications we have. Another important thing, which is the, see, when we place the proximal humerus is the stem, to decide how much a stem should be out, because proximally there is nothing. If the GT is present, we can keep it at the GT level. The edge of the stem can be at the GT level. But here, the main problem what we have is the GT is not there. A subsequent chunk of the GT, LT is gone. Though how to fix it up? So the ideal way to do that is, one, intraoperatively, how we do it is like, we look at the pec major. Pec major attachment, you measure 5.6 centimeters up. So that should be the upper border of the stem. That gives us an idea. Normally, this works very well. So I always make sure that I do a measurement and then do it in this kind of cases where the GT is not there. I do the same in reverse as well. So works well. Second is, we have to do a comparative X-ray, find out how much to keep outside, and then do it. On the opposite side, we do a comparative X-ray and then do it. Coming to the RSAs. So RSAs, now the age limit, it is like earlier, like physiological age of 65 years. Now, if this particular gentleman is the person who I told about, who have done a hemiarthroplasty at 38 years old, or 35 years old is coming, and definitely he'll require some revision. So I even do it around 50 years. Above 50 years, I do definitely do an RSA. I'll tell the possibility of a revision after 15 years, but definitely I do it. Definitely, if there is no other go. So again, the indications are the same. So there's no difference in the indication. The main thing I would keep as a criteria would be that the patient should have a good function. Otherwise, should be an active patient, should be well motivated for a good rehab process. Then the RSA in proximal humerus is very good. It's a good choice if there is no other choices. Contraindications are the main thing: deltoid insufficiency, axonal nerve dysfunction, infection, medically unwell, shock of joints. These are the again glenoid bone stock. So that's important thing. It is just not the proximal humerus. So the glenoid stock is important. I'll be showing one non-union which I had to do a reverse, but I can see that logged posterior dislocations, neglected dislocations. These kind of cases, glenoid bone stock is an issue. So even if you do the fracture fixation will not work, you need to replace both the sides. So then you're going for a reverse. Preoperative planning, the standard X-ray is fine. The CT, yes, now we have advanced VR technologies, virtual realities of HoloLens with evolutus, and robotics is also coming in, where CTs are integrated, and even on evolutus HoloLens Microsoft platform. So they integrate the CTs do a reconstruction and then plan out, find out exactly a lot of things. One, we can actually decide the sizing. We can actually see where exactly the entry point should be, especially in a neglected case where there is a malunion, a lot of extra bone growth is there. We can actually find out which is the best place to do it. MRI, if for example, if it's a case who's coming to us after maybe a month or so, I would like to know the soft tissue integrity. Again, I would definitely look at an MRI, and preoperative height measurement can be done. So, what is my position? When I visited many surgeons, okay, they have each would have their own technique, but there are surgeons who do it completely supine. I do it in the V chair, 45 degrees or maybe slightly up. So that gives me, I don't have to strain too much to do it, and gives, I'm quite comfortable with it. That's why I do it in that position. Tranexamic acid, sometimes I don't, but if I find intraoperatively, I might give if I'm feeling that some bleeding is there, not under control. Approaches the deltopectoral, which I mentioned now. Here, to mention a few things about in the reverse. So the CA ligament, normally once we go inside to see the conjoint tendon, see the coracoid process, and then so normally I release the CA so that I get a little more space to maneuver and deal with my subscapularis. And then another important thing when we do reverse or a hemi is that, see, for the subscap movement, subscap should be free. That means the space between the conjoint tendon and the subscap should be free. So normally I take a scissor and bluntly, I don't dissect too much, we just open it, okay? So that, and I just with my finger, I make a space there. After releasing the subscap, we should elevate also on the scapular surface. This is one of the keys, because a smooth subscap is important in reduction later, and also in a subscap refixation. That is one of the keys, especially this is important when we look at cuff tear arthropathies or arthritis scenarios. Next, the regular deltopectoral approach, which I mentioned earlier. And here I've taken bites in the GT, LT, and I've taken the remaining chunk of the humerus out. And I always prepare the humerus first, and then I go in for the glenoid. So here, am I audible? Vivek?
Yes, you are audible.
Yeah, okay. So here, these are the different steps, okay, the jig placement. This is for a non-fracture case. A fracture case I'll come to a little later. But the steps are the same. That means here, there is only so much of the humerus. So you can make the entry easily. You keep on dreaming till you get finding out the hand dreaming till you find out adequate size. Then you broach it. You can see this jig. You can see the alignment of the jig, how it is. You can keep it. See this wire here. This wire will be parallel to the elbow. So the evaluator's recommendation on 20 degrees. But when I went for my training, they used to do it at 30. And my boss is very much particular that he told me specifically I should keep it 30 because that is a key. And you make that, then once you've done this, then you broach. Then the glenoid preparation. The first step in the glenoid is that we have to see how to identify the glenoid or go into the glenoid. Is when you cut out the biceps, it will away from its attachment. Long at biceps, travel along that, then you will reach the glenoid. That biceps is the I would say that the landmark how to go around it, because especially if the patient is coming with a malunion and a lot of fibrosis, sometimes it's very difficult. A lot of soft tissues inside. It is very, very difficult to visualize it. So I sometimes have to take multiple C-arm shots to find out exactly where there's so much of soft tissue there. High chance of, because all this card of high chance of brachial plexus injury and all that. So once I am inside, okay, so here we have different types of retractors like the Fukuda and all that. But technically, I don't need all that, because I can very well manage with little broad home and retractors. 3 I take. 1 I keep it in this, that is above, posterior, and inferior. And if I have to expose anteriorly, I do that. Then we have to entirely remove this. The entire thing of the labrum has to be removed, and we have to denude it. Then we have to find out the entry point. So the ideal entry point is, suppose you mark this, the equator, it is somewhere here. So this actually inferiorizes the base plate. The base plate will come down like this, and that prevents from notching and better movement. So this is what I was talking about, that it is ideal. So if it's a glenoid, ideal to keep the base plate maximum inferior, so that the glenosphere would be like this, and so that notching means the cup would be coming like this, and if it is slightly more higher up, it will come and hit here and eventually cause erosions in this area. That is called notching. To prevent the notching, we can do this. So do this, and also we can put a 10-degree tilt. You can see tilted. So I don't do much of tilting because then I have to take little bone over this area. So I would inferiorize it than tilt it. The different types of stems which you can use. So now the ability stem, I was telling you, the fracture stems are 15 mm longer, and they've got proximally it is coated for bone integration. This is what I was talking about. You see here, it is very difficult to. So two things important here is, one, broaching. We might not get because if it is a non-fracture case, it'll get stuck there. We know this will not move. But here we keep broaching so that some indentation happens into the medullary cavity. Every time we broach it, finding the adequate size, we should always think that the 30 degrees is maintained like this. And I was saying 5.6 centimeter is the average from the pec attachment, pec major to here. I'm so sorry. Yeah. So now coming to the most important thing is bringing back the fracture fragments and holding it together with different the earlier technique which I described. Now, here, two problems which we have, especially in fracture scenarios, are instability. In spite of putting in retroversion, you can have it could be unstable. Why? Because in fractures, soft tissues are quite lax. So getting that, there are high chance of dislocations when you do especially a reverse. So what we do is we can do a lot of, especially this process which I use. One, I find it apt for our group of patients, means smaller patients like in Nepal and in India, because we have smaller base plates. Earlier, I've done the Zimmer biomet, but I've done the Arthrex. I find the central peg area where you put a central screw in the base plate. So big chunks of the bone come out. There is nothing but a significant amount of bone is gone. This particular implant, I find it very useful because very minimal bone loss in the center. Then I was coming to the instability. How do we adjust the stability? Stability can be adjusted by adjusting the length of this length can be adjusted. How? So one, we can keep the implant proud. I can keep this slightly little more outside. So I have to do by checking. So what do? I reduce the implant. So this is one trick I do. So I reduce it. I know that this is not fixed anywhere. I've not simulated it yet. So what I do is I reduce it. Then I adjust, I pull it up. I pull this stem up so that it is coming and sitting properly. Then I mark this area. I mark like this point where I know how many, if there is no marking available, then I measure it from here to here. And I mark it exactly. That means from here, I take a scale and mark it. I know that I have to keep 6 centimeter outside. So because I've already reduced it. And in the reduction position, I find out where exactly and keep it. And then I can cement in the same position. So the thing is, you can keep it proud. And suppose after cementing, you're getting stuck, then what we can do is we have thicker offsets. We have deep trace, thicker offsets. These implants have this adjustment device. So you can see this is like a pen kind of thing which goes here. If you rotate it, this will become little more tighter. Offset increases. And whichever we find, there are different sizes which come, 2.0 plus 2.5 plus 5. So whichever we find an adequate size, we can actually put it up there. And because adequate, how much we adjust here, there is a particular poly for that. So insert is there. So we can put our insert. So I always do a trial after fixing the before cementing. After cementing, I do at least 3 trials because I don't believe in taking a risk. So this is what I was trying to tell. So reduction. So that is one adjustment we can do in the processes. Suppose the processes adjustments are over, nothing else, it's still slightly tight. So then the key is we can release the long head of the triceps. So what we do is, okay, we take a like an elevator, what you have in the Cobb's elevator, which you have in the spine, keep it just under the glenoid and elevate it with a cautery. And don't do too much, do once at a time. So that is the second. First is the subscap, the key. So scarring of the subscap. Second is the triceps. In one particular case, it was a little more tight, so I had to release the conjoint tendon partially near its insertion, and after reduction, I switch it up. So then, how do I decide this is the appropriate fit? But it was the same as like a hip you do a shuck test. Too much opening should not be there. Too much, that means okay, maybe like 3 millimeter, 4 millimeter opening, or when you do the shuck is the ideal. So these are the tips which I feel, which I have learned from many teachers who are very kind to teach me that these are the things which I can get away with it. Then another important thing is, see, when we do, when we don't have in our countries, we don't have sophisticated hand tractions and all that. We don't have hand positioners. I feel that you don't require it. What I've seen is, so all you require is a good Mayo trolley. So if you keep for example, when I start the procedure, I keep the hand straight. So after some time, when I do the delta pectoral approach, I open it up, and then I go on to the GT. So what I do is, when I'm doing the GT, I keep my hand abducted, external-rotated on the Mayo. So it will rest completely on the Mayo, and then it easily comes. We don't require anything at all. So we don't have to struggle too much to see it. It is basically an adjustment with the height of the Mayo trolley and the position of the hand. So then that is another thing. And then coming to the reduction, most of the fractures happen with reduction. So the surgeon himself should do the reduction. Two people should never do the reduction. So how to hold? The hold should be on the hold should be on the poly. That means your insert. That area should hold near the plate, that base plate, not the base plate, okay, the humerus plate. And you should hold it there, that is near the poly, and you should one finger there, and then give traction on the elbow. It should be the same kind of traction which is used for putting in, putting out. It should be simple. It should not be, we should not use too much of a traction, I mean rotation. Definitely end up in rotational fractures. So these are the things which I felt was important. And antibiotic cements, yes. So whenever you use cement, antibiotic load cements are used. I think I covered most of the things. And tuberosity fixation. Complication, we know the regular complication, but most important dreaded complication is the infection. So hemis also can get infected, reverses can get infected. So they come with outright discharges, and sometimes you can pick it up much early, and definitely a thorough debridement. I do a thorough debridement kit. I'm very, very cautious about controlling the diabetes and the other comorbidities. I wash it out immediately, and I have never had to remove the implant till now. But I've seen, in my training, I've seen where it is so horrible to see it. But so thinking that the patient is undergoing a revision after almost like 6 months. So the implant was explanted, antibiotic spacer was put, and a custom-made process had to be put next time. So we are not into custom-made process yet. Evolutus has some revision element in the glenoids, but still we are not proper custom. For example, it's a big fragment in the, we lose a big fragment in the humerus. We're still not into that kind of custom, but definitely it is there. Then instabilities are there, neurological complication. I had one neurological complication where it is very odd. It is a fracture case, neglected fracture. I'll show that X-ray now. So what happened was the patient preoperatively, almost like 2 months, patient had it was neglected, and that particular case I didn't take the sutures. I was extra confident in that time about this. So uh, I always do a fluoroscopic movement. That means movement of the shoulder after the reduction. So with the before the final implantation done, I do with the trial I do. With the for the stem fit, I see a one shot, and then lastly I take a fluoroscopy to see that everything is stable. So during the fluoroscopy, I found that very odd during adduction it was coming out. In adduction position, it was getting dislocated. I changed into this whatever I told earlier, a longer processes. That means I dissect this, a longer poly, a deep poly was put and it became stable. But in the process, I already had dislocated around that, moved it around 5-6 times. And the patient had a transient neuropraxia involving brachial plexus, posterior cord brachial plexus. Patient had 2/5, 3/5 power in the biceps. Axillary one, it took around 6 months to recover. So definitely is there. So we have to be extremely careful, and we have to be careful during the dissection, especially in the axillary nerve area. That is where I told just now, where it is where we release the triceps. We have to be extremely careful. Put a finger there, put the corpse, elevate it, push it nicely, and then elevate it. Definitely, they do recover well. Procedures to any other procedure where neurological complications are rarely described. Glenoid complications, glenoid fractures could be there. Scapular fractures can also be there. This is an interesting case we had. 60-year-old female patient, history of seizure disorders, neglected posterior fracture dislocation. Patient was from Bangladesh, and this was the case. You can see it is posterior dislocated, logged, no bone stock. And the important thing, you could see that, when the CT, when we do a 3D, we can see that very interesting fact. We can see that this head fragment, the remaining head, see this head is actually sitting on the antero-inferior, in the posterior-inferior area. Posterior-inferiorly, it was jammed and it is united there. So, and the CT showed that. So after, it took me it takes a little time to do this because, I had to dissect after the deltopector, I dissect almost like 15-20 minutes to reach the glenoid. Because a lot of fibrous tissue. And once I found that it is, I'm not getting the shape. And there was a defect here. This defect was there. So this is the defect. And this is the green is a malunited head. So I decided to cut it, osteotomize it, and shape it and put it back here. It fit nicely like this. So, and then I modified my entry, that is the wire entry and the base plate entry slightly. And so that my screw would be here, 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 here. And this is the final picture. It came out nice. The fluoroscopy also was quite good, stable. Patient is recovering very well. So this is another case, interesting case of this failed case. So again, we had to remove the implant, but there is nothing to fix back. You can see only so much of you can see the fracture here, only so much is there. And again, good results. The patient went on to do very well. Failed conservative. So this again had a significant bone chunk and did this. Acute 4-part head splitting. Again, this was the answer. How much movement can we expect? Around 130 to 140 degrees forward elevation. External rotation around varies 30-40 degrees. And pretty good results. They go on to have good power, 5/5 power. So my protocol is like this: first 6 weeks immobilize, then after that start with passive range, active assisted, isometrics, and then go on to especially work with the deltoid and the scapula. So the deltoid and the lower scapula muscles, the trapezius, lower trapezius, the key to recovery. So if activated well, which we do, especially lower trapezius activity, they've gone on to have good results. But time taken is like around 4.5-5 months. So normally I tell the patients in advance that this is going to take time, the 5 months, but they go on to have good recoveries. RSF compared to Hemi has excellent results. much more movements than the Hemi. This video is not very clear. It was not intended for this talk, but I had just taken it some time back. So I don't know how much I can explain. This is actually the jig. So this jig actually we are the remaining what you can't see is the elbow is down here, and you can see that it is in 30 degrees like this, and then jig is placed. Once it is placed, I'm getting the correct version. You resect the damaged humeral head. The broaching, you can see that maintaining that position, we have to be extremely careful. So I'm keeping in this, how much away, 120, 30 degrees. And so this is the glenoid, okay, so I'm just exposing the glenoid, and I've cleaned up the glenoid. The glenosphere has been actually put, tapped. I wish I could actually show a better video. I don't have that at present. And that is a unsimulated processes, a regular stem. You can see this coated. So the other one is coated only proximally. And see the reduction. So see, when I'm reducing it, one half finger is there, and the other. So it is simple to reduce in the final video. So these are the two videos which I mentioned. So you can see that it's pretty challenging, but it is very satisfying in this particular case. The defect prepared. I would wind up the fracture proximal humerus with that. I'll quickly go on to the label reconstruction. So label reconstruction or the DAS procedure.
Dr. Nair, sorry to interrupt you. So can we take some questions because there are some questions in chat.
So I'll just.
So Amit Joshi sir has asked, when do you do CT scan or MRI, and how to decide which one to do in case of proximal humerus fracture?
CT is always better, so because CT is mandatory that we do a CT, so that we have a good idea about where exactly the fragments are, and how to manipulate the fragments, or even when you're planning for non-union or delayed union case, CT, yes. But then soft tissues, there are, for example, if it is delayed union or non-union or even AVN, a case like that, I would preferably like to retain some part of the cuff. But I would be mentally prepared if I see the MRI. MRI not mandatory, but CT is always mandatory.
Okay. So what about knob conduction test, knob studies?
Yes.
Usually what happens in four-part fracture, fracture dislocation, the head goes and is right over the brachial plexus. So how commonly you do the knob conduction studies?
I do always clinically. I don't do a nerve conduction test mandatorily for all cases. But if I suspect, I will always do a clinical examination, see that a sensory testing. I do the other testings. For example, this particular patient, nerve injury also, okay, I've tested preoperatively, had good function. So, but if I suspect something, definitely, but I make a note. But nerve conduction, I don't do on a regular basis. But for medical legal purposes, definitely nerve conduction would help.
Okay, so what are your indications to do knob conduction study? So my question is that another way of asking my question: have you come across some cases where you have done hemiarthroplasty or osteosynthesis and later on found that the deltoid is not working? Because deltoid, the function of deltoid is the very important thing in the result, right, in rehab and all. So are there any such cases of yours?
Yes, okay. This particular one particular case which I mentioned, so preoperatively nerve conduction test was not done. So because I didn't feel it was required, clinical examination showed good movements, and the deltoid also acting well. The regimental badge was negative, so all was good. But I clinically documented that the patient didn't have it. So then postoperatively the patient did have. So because of the traction, because I had that particular case, I had to dislocate, reduce multiple times. Possibly because of the traction, it definitely ended up in neuropraxia. I did have, but it went on to recover in 6 months. So definitely, if you to keep it straight, nerve conduction is ideal, so that you're documented very well. And
Okay.
nerve conduction also tells us that if we have to do if deltoid is good or not. So
Okay.
definitely for all purposes, it is excellent, and for medical legal purposes, it is excellent that we do it. But if you ask me, do I do it regularly? I don't, because I clinically document it. If I
Absolutely.
suspect preoperatively, till now I didn't have any case where I suspected preoperatively. But if I suspect with anything in the neurological examination, definitely I'll do it.
Okay. There is another question from Dr. Susil Thapa. He asks, in posteromedial combination, where do we put the cement for augmentation? At the posteromedial portion, or bony defect, or into the drill holes?
No, the posteromedial bone cement, which I mentioned, was for the screws in the proximal in the head. So cement we put only in the head. That means you drill, you can inject the cement there, you can put a screw off. So we can also coat the screw and then put it inside. So if there is a posteromedial combination, definitely we have to do a corticocancellous graft from the iliac crest, graft it, or fibula stud grafting. So we should not use cement there in the posteromedial comminuted area. But the cement is basically for the proximal screws, head screws.
Okay. Okay. For the strength, right?
Right, so that it doesn't penetrate further. So it gets jammed there at the end of the hole, screw hole. So it doesn't allow a further penetration.
Okay. Okay.
And it gets stuck very nicely inside.
So what about your position during your osteosynthesis of proximal humerus fracture? Do you always do in 70 degree, 60 degree beach chair position, or you do just supine position with some bolster over the scapula, or what is your preferred method?
Normally, because I am comfortable in the beach chair, I always do a beach chair. So which varies like around 45-50 degrees. I find it comfortable.
So where will be the position of your CM? Because this is
so CM comes from the opposite side or from behind. That is from behind the patient head.
Okay. So,
or from the opposite side.
Okay. Okay.
So when it is lifted up, actually, so we have to tilt the CM, but we can do that. So we keep. So I normally take a shot before the CM. Normally I keep it from the opposite side, so that we clear up everything and it is in position. And we'll tell the technician to keep it at this particular angle. Don't move it.
Okay. So Amit sir has asked another question. Where does Hemi stands in your practice in proximal humerus fracture?
Yes. So if the patient is like head splitting fracture, there is a non-union avascular necrosis, and the patient is not functionally good. That means above 70 years, not so active patient. Then I will do that. Second is again the most important thing which I feel which is nowadays and which I feel is, and there are recommendations also, the patient is not old enough to do a reverse, but if the patient has got good GT-LT chunks, and it is a non-union, delayed union kind of fracture pattern, or a revision fracture pattern, and so in those kind of cases, again, I do the Hemi. So definitely I will tell the patient that, see, 15 years down the line, after you cross your 55 years, if the main thing what happens is the cuff will have attrition over a period of time, and the function might come down. We tell the patient that. So eventually in the future, if your function is coming down, so if you develop pain, and if there is a glenoid wear out, especially young patient, definitely we will have glenoid wear out. So in the future, he's counseled for a conversion to reverse, where we can do the reverse without changing anything other than the stem will be the same. If the stem is in good place, we don't have to change the stem. So this evolutus we can change only the glenoid in this part. So that is an excellent option. These are two scenarios which I do the Hemi.
So in your practice, Dr. Nair, what is the percentage, if you have to give us percentage, conservative, osteosynthesis, hemiarthroplasty, and replacement, reverse?
So it is in the 80%. It is because most of the fractures which I have are 3-part, 4-part, and they are younger populations, and also I have population like 50-60 age group also. But whenever there's a possibility, I feel that this particular patient can benefit from an osteosynthesis, I always do that. But if I feel that, for example, high chance of AVN, that means our metaphyseal calcar is less, head splitting, and metaphyseal comminution is too much, and if the patient is definitely above 50 years old, and then these kind of scenarios, I will go in for a reverse. And my only, that means in my practice, 10% is reverse, and around 80% would be the osteosynthesis. Under 10% who are like very old population would be not much of functional demand. A patient like 70, 75 years old, but I would like to give them some function. The fracture is in a very bad condition. So then definitely I'll do that. I'll go in. And if the fracture is, if I in the same age group, the patient is like 70 years old, the fracture is, I do a fracture fixation is failed, revision, I'll go and do an hemi. So it mostly depends upon the patient function, that is physiologically older age group. And that means around again 10% is my hemi patients.
Okay.
And in young patient, I do a, like this particular patient which I mentioned, we do a uncemented hemi.
Okay.
And in older patient, we do a cemented hemi.
So there's a question from Amit sir.
Dr. Ayyapan, thank you very much. That was excellent talk, giving, highlighting so many things. My question is, in Nepal, in our part of the world, reverse is not that much very regularly done, and the cost of reverse is very, very high in our part of the world. So there is an overlap when you decide either you can do both hemi, you can do reverse as well in that patient. So as the standard teaching, if you can reconstruct in fracture cases, if you can reconstruct the GT and LT, probably your hemi is going to function equally well in case of trauma scenario. So are we, making reverse shoulder indication more, or the indication are clear cut? In this case, you go ahead with the reverse shoulder, or you can even get away with the hemi shoulder arthroplasty.
Yes, sir. So the indications are like this. So the patient is not, he's got a unreconstructable head. That means completely comminuted, or the patient is coming with a neglected case, failed case, and the patient is young. We should do a hemi only. For example, patient is like a 35 years old. Till 50 years, we should try to do a hemi only in such cases. That is very important. If we do a reverse there, he will end up in at least 3 revisions in his lifetime. It's very difficult to considering that. So that is one indication. Coming to the older age group, the entire thing depends upon the patient's function. When you compare hemi versus reverse, reverse will give excellent functions. At the same time, hemi gives like half the function, 90 degrees, 100 degrees. Entirely depends upon the patient's function. That's what is the functional requirement of the patient. I would say that is the answer, sir.
Absolutely. Thank you.
So final question before proceeding to another lecture. So when you do osteosynthesis, because many of practice in Nepal is osteosynthesis than arthroplasty, I would like to focus in osteosynthesis only. So when you do osteosynthesis, what are the augmentation you do for that fixation? Is it always, or is it optional?
Right. So see, augmentation I do only with the bone cement, and I do the corticocancellous grafting in the posteromedial area. So how do I check? Okay, after the reduction is done, so preoperatively the CT will definitely give me an idea. After the reduction is done, the plate is also in place. Then I will know how much of posteromedial space is still there. So you can actually see it, feel it actually. So then I do a corticocancellous grafting, number one. Then, for example, if the patient is osteoporotic, how do we know it is osteoporotic? Like one, the patient is age itself is one. Second is when you're putting the calca screw or the proximal screws. I feel that I don't have, when the drill is going in, first I would definitely do a drill and see if it's going in too smooth inside, and the even the tap, or even the, I would say the depth gauge. So I would take the depth gauge. Even for drilling, I take the depth gauge. You can push the depth gauge inside. If I feel that depth gauge is going smoothly easily up to subchondral bone, then definitely I'll put a bone cement. I don't have experience with the calcium phosphate and the sulfate, but definitely they are very much in use abroad. But I think cement in our practice, I think cement can be definitely used. So these are my specific indications.
So what about the cough sutures? Cough sutures, you pass sutures over subscap, supra, infra, and all.
And that is definitely there. So
always or optional?
Yes. always. So first thing I even before I do anything, I do always take the sutures. Suture and suture, I think should be the key to reduction as well as holding up. So the sutures are the mandatory thing. I think
Absolutely.
the first thing and the most important thing should be, I think, the sutures. How many of our sutures that passing through the plate is ideal.
Okay, thank you so much. That was the point I wanted to bring about. So I think there are no more questions. Let's go up. Let's go on with the second presentation. I think you are okay. We have really.
Absolutely. So right now I'll go on to the dynamic anterior stabilization. So what happened was, when we look at our vanguards, so there are failure of vanguards. So if you look at literature talks about even up to 1/3, 35% also there are revision or recurrence rates after a vanguard repair. Now, so when we looked at, we have Pascal Boileau paper talking about different reasons why we have it. But I think one of the main reasons would be when you look at Pascal Boileau's ISI score, as well as the causes of revision or failure of the primary vanguard. One is high demand. For example, if it's a contact athlete, such a patient, the vanguard is supposed to fail. So in a contact athlete, he says that you should do a Latarjet or a bony augmentation. Then all of us know that if it is, there are different papers talking about the bone loss, glenoid bone loss. Glenoid bone loss, earlier it was like 30% bone loss, you do Latarjet, 20%, 25%. Now it is like 13.5%, according to latest paper. So now in my practice, 15% is the cutoff. Above 15%, I would do a Latarjet, because I feel that when you actually look at the thickness of the coracoid and all that, we find that, and we did our own study where we found that in spite of doing a Latarjet, the glenoid continues to off track in at least 30% of our patients. So that is because the glenoid is, the Latarjet is not the answer for everything. So that is in those kind of scenarios, more than 15%, I would definitely do a Latarjet. But there are subgroup of our patients. What about patients between 15 and 10%? So aren't there patient who's got an Alpsal issue, who's got soft tissue insufficiency, who's got, when we find that severely atrophied labrum is not there. In those kind of cases, what do we do? And second, we also have revision vanguard scenarios where bone loss is still okay, but because we still do a Latarjet, if a vanguard fails, we still do a Latarjet even if the bone loss is like 5%. So why? Because Latarjet produces a sling effect, where the conjoint and tendon acts like a sling and it posteriorizes, pushes back the head. So now that is when this concept of dynamic anterior stabilization. So when we look at literature, what we can find is that people have done also with the instead of the Latarjet, they've also taken the short head of the biceps, conjoint tendon, and done this dynamic anterior stabilization. So stabilization, where they've made a split in the subscapularis, drilled a hole, and passed the conjoint tendon through and fixed it with screw and all that. But the bone was not taken because they felt that bony augmentation was not required. Didn't have excellent results. When you look at the results of that, only 2-3 papers are there, but didn't have excellent results. But this Philip Collins suggested dynamic anterior stabilization with the long head of the biceps, where the long head of the biceps is cut from the glenoid end. We can take it out, split the subscapularis at 3 o'clock position, make a hole, and fix it with different techniques. So he fixed it with the screw. There are other people who have fixed it with suture anchors, and so I modified, because so I felt that why can't we do something similar to the to the ACL, make it simple. Why can't we drill it from anterior to posterior and pass ACL tightrope kind of thing, and then pull it out? It will be minimally invasive and we can pull it through. That was my thought. So we started working on that. So before we go into, so I'll just say the indications. By indication, there are more than 15% of bone loss, severe labral soft tissue insufficiency, or a failed Bankart. Young patient is an overhead athlete or throwers. Contact athlete or professional athletes whose IC score is more than 6. In these kind of scenarios, I've been using this now. But these scenarios, I did more than 15%, again, it is a retardant. So contraindications are LHB should be good. If it's a bad LHB, you can't do it. So there are biomechanical studies also showing how it works. Interestingly, we also went to MS Ramaya cadaver lab and we also tried this technique. We saw how this was moving. The biceps, long adult biceps is moving on top of the subscap and how it was functioning. We also did FEM studies, finite element studies. We have not published it yet, to see how this works. And this is Philip Collins' 2-year results, original paper, saying that there's a good option and biomechanically also it's good and it works very well. These are different modifications, the different sutures and things you get. Like we can fix the biceps in the hole, in the anterior surface of the glenoid with a screw interference fit. We can also do a swivel lock. We can also use suture anchors also just to pull it. And so we did this where we took the arthrex. There's a quadriceps tightrope is there, ACL quadriceps tightrope. I felt it was a good option. So what I did was, it has got a tape which passes, we can put on top of the tendon and we can suture it. And we indirectly, how we do the ACL, like the shuttling technique, we can pass it through the glenoid and anterior to posterior, flip it, shuttle it, and then push it in. I felt it was good, simple, smaller hole, drill holes, not much, only threads are there. So you don't have the problems of screws and other things are not there. I found it was good. So this is the technique.
This video is on the dynamic anterior stabilization using fiber tag tightrope. We do a diagnostic arthroscopy. The heel sash is visualized, prepared, and the implissage is done with triple loaded anchors. The tie of the implissage is done much later after the labral preparation and the Bankart to PAM. This is the labrum being prepared, the bed mobilized, the labrum is mobilized and elevated till 6:30. The first anchor is applied at 6:30, followed by the 5 o'clock. And then the 3:30 positions. That's a preparation of the bone bed for the IGHL plication. That the plication and a nice bumper formation there. Now the biceps is prepared, and before the bicep preparation, the rotator interval is released, and the biceps is mobilized using cinch sutures. Here, a tie is taken to the biceps with cinch sutures. The biceps is cut, and it is retrieved through the E port, through the cannula, and the biceps is immobilized in the subacromial space till the upper border pectoral is made. The biceps is pulled out through the D port and the fiber tag is applied, size to 6 millimeters. A trans-subscap port is made, and at 3 o'clock position, a clear cannula is passed over the basing rod. The antisurface of the glenoid is visualized and bead pin passed, and the 6 mm reamer on top of it to 15 millimeters. The LHP is shuttled, long end is shuttled into this giant tortuous tunnel. The tightrope going in, the button, and then gradually pulled into the giant tortuous tunnel. This is a final label repair at 2 o'clock position, where the labrum is also plicated onto the glenoid surface, and there's the final repair with the dynamic anterior stabilization and the bankard repair. The implicit is done after this.
That was the technique we did. And we went on to modify it even further. So this is another interesting case where we had, it was a straightforward case. So 5-time dislocation, 35-year-old male patient, Baton score is good, and 1.3% bone loss. So very, very straightforward. And I planned in for a regular cuff repair. But it is very interesting to see what we had inside. So there is severe soft tissue insufficiency. So my option here was, okay, such kind of insufficiency. So you can see that's a Hilsage. So I've done an amplissage, and I'm elevating the labrum and the capsule. I'll skip on to the soft tissue bankard repair. So what I found was it was very, very tight. You can see that. So it is unimaginably tight. So in spite of taking a nice release, okay, so normally I release it very well. So still I found out, okay, that's a tightness. So in this kind of cases, so I wanted, this head is still slightly towards the anterior. You can see that. So the head is still not centralized. So here my option was, okay, so I have to placate it back. I have to centralize it. So here I went in for an HB release. So that is releasing the biceps in the subacromial space. And again, subscap split. Next, okay, I'm pulling through the tunnel, that is through the split in the subscap. From the posterior port, I pulled the biceps inside. That is almost 2 centimeters of the bicep pulled inside. Anchored it with a swivel lock on the anterior glenoid surface. So that is an anchoring point. So from this point, next, what I was planning is to do a labral reconstruction. Now the biceps is with this, entirely with this, okay, once you fix it, it is already, the head is reduced back. So now, and the tension on the anterior sutures have reduced. Now I'm taking the biceps and I'm doing a labral reconstruction with the biceps. What I've done is I'm pulling it down, and in the gapping area, so I'm superimposing, that means I'm putting all sutures there and then suturing it down. So that there is now it is reduced. You can see the tension is reduced automatically. And lastly, I'm having a fresh new labrum. It's a beautiful labrum which came up. One, it gives a bumper. More than that, it gives a sling. And next, it is helping reducing the tension on the capsule. And it is acting as a cover on top of it, because the sutures are exactly put on top. I'm covering it and protecting the repair. So this is the biceps. This has been described. So the labral reconstruction, this is not the first time this is done. It's been already described before, but we modified it slightly.
Okay. Thank you, Dr. Nair. That was wonderful technique, and congratulations for your publication in arthroscopy technique. So I have a question. So how do you do about the subscap split? You do outside in, because in arthroletargy you go inside out, right?
Correct.
Yes.
So what we did was, we went to the lab. We tried to find out which is the ideal port for splitting the subscap. Okay. So what I found was, when we actually have, so we have the port here would be the J port here, and J port would be halfway between the acromion and the axillar fold. So J port is too lateral. That means if I go like this, it will exit, the entry will exit. That is a button will exit quite a bit medial to the medial and posterior in the scapula. So then I did the M port. M port is like 3 fingers away from here, 4 fingers away. And M port is the port which you use for drilling when you do the arthroscopic letargy. But the problem in the M port was, what I found was when we did the trajectory, so I dissected out, tried to find out which is the ideal trajectory to go in. The conjoint tendon was coming in the way. So I decided the I port is between the J and the M, middle. That is exactly in line. That there's no neurovascular structures in that area because there's I ports. It's somewhere just on top of the pec major, where somewhere in that area. It is on the lateral to the conjoint tendon, safe area. So now, I put just a skin incision there, where in the I port area, then blindly passes and the Wisinger rod. The Wisinger rod, it will easily come into the rotator interval. You can see it properly. And then my port, I would have switched on to an anterosuperior viewing port. This anterosuperior viewing port, I can see the outer side of the subscap as well as the inner side of the subscap properly. So then I know this is the entry point. So what I do is, so once I have seen that, then I take my RF, pass in the same trajectory on top of the subscap. Posteriorly, what I do is, now I'm doing from the anterosuperior port. So I take a Wisinger rod through the posterior port. I indent it, tent it. That tenting point, I would dissect anteriorly. You don't need big dissection because the tendon is small. You don't need a big dissection. Only like 2 centimeter dissection is enough. So then it will easily come in.
So my next question is, to have that sling effect, you have to have subscap upper 2/3 and lower 1/3. There must be some mobility when patient does this vulnerable position, abduction and external rotation. The lower part of the subscap must have some movement. So if you are making very small window at that subscap split, will it act as the subscap spling, just like in open letargy or the arthroletargy, because you are making very small hole at the subscap?
No, we actually have to split it horizontally, starting, and that is on this is the glenoid. So on the lateral side of the glenoid, slightly maybe 2 centimeter to the middle side of the glenoid.
Okay.
So definitely some place there. Second, we can't see like the letargy. Because letargy, we are putting it inferiorly. I can split the subscap even further down. My splitting point is at 5 o'clock position or 6 o'clock position. I pass at 6 o'clock position. That is where I split. So it becomes upper 2/3 and lower 1/3. It becomes like that. In these cases, you can do only the upper. You can't do the upper 2/3. You can't do it. You can put it only up. Then coming to the stability pattern, yes, we did the biomechanically. We checked it. So we are working on the data on that. We're trying to get the data to see how much is the stability. Is there any translation which is happening? All that we have tied up with the engineering college. We're trying to see how much the FM study we're doing it. We're also planning a cadaveric biomechanical study to see how this is working. But what we found was definitely it is holding well. So when we visualize it through the cadaver, what you find is when you move the shoulder and see, you can actually see that one, it immediately goes back. Second, you can see it moving on the subscap. You can see it moving, and you can see the subscap is also moving well. Then coming to the last part of the question, so see, there are cases of subscap tenodesis. There's a lot of surgeons who have a subscapular stenosis. So, will the function of the subscap be affected? From our we feel that stability is definitely there. But definitely, I agree to the point that there's definitely some amount of subscap mobility would be affected. But when you look at powers of patients who have done subscapular stenosis, they do pretty well. So here we are not denuding the subscap. Definitely, we are allowing some movements, and this is actually quite flexible. The ligament, the tendon, actually, it is not a sturdy thing. That's why it is dynamic. It actually helps you move quite well, nicely, and gives a continuous link.
Okay, true. Okay, so my final question, do you need to dissect the knob just like in arthroletargy in DS, or you can just go directly the subscap split?
You need not dissect at all, because initially when I did a cadaveric study, just for me to understand, okay, how this is going, how well it is going, where exactly it is going, I did a anterior. I did in V-chair position. and I also visualized from anteriorly completely. So I did all the regular dissections as an arthroscopic Latache, how it had to be done. But then after doing that, I realized that that is not required. Now I do only in lateral, and you don't have to dissect at all. If you're using the I port is between the J and the M port, you just have to go in directly, it will come. So you don't have to do minimal dissection on the anterior surface of the subscap is required, that's all. And you can even preserve the labrum, whatever remaining labrum is there, you can preserve that, because you will be going through the subscap and coming, you can lift up the labrum and drill it under.
Okay, next time when we meet, I think we have to learn this eye portal. Thank you, Dr. Ayyapan. That was very nice talk. And thank you so much for taking all trouble. It's been, I think, 1.5 hours you have been speaking. Thank you so much. So if anything you have to tell to our Nepali colleagues, you are welcome. Please, Dr. Ayyapan.
It is extremely nice of you. And I've been seeing Amit Joshi sir, you everywhere, all the other surgeons from Nepal. It is very exciting to see the work you're doing. And I'm a big fan of Bibek's as well as Amit sir's. Bibek's okay. I've been actually looking at your patella. It is a wonderful thing, So the kind of work you're doing is really wonderful. So I actually recommended that to a lot of surgeons who came with the patella, the work. It's beautiful to see the kind of excitement which is happening, and the energy which you have. It's very good. Keep going strong. And I was telling you that I had a lot of good friends, but I need to catch up with them. I don't know, Suman sir. I don't know if you know him, Suman Shrestha.
Yeah, he was here. He was here, I think.
So can you send his number if you don't mind yet?
Okay, sure, I'll send you.
I would like to catch up with him because it's a long time. I think it's more than 8-9 years now.
And next one you said Prayatna Rajwanta, right?
Pratendra Raj. Yeah.
You need to come to Nepal, Ayyapan, to meet them physically, rather than just over the telephone. So
sure, sir.
Looking forward to see you in Nepal very soon.
Sure, sir. Thank you so much, sir. Thanks, Vivek. Thanks, everybody.
Okay. So I think we are already hitting 6:47 p.m. here in Nepal. So let's have a closing remarks from our president-elect, Professor Amit Joshi. I said vice president at the start. Actually, he is president-elect.
Thank you very much, Dr. Ayyapan. It was so enlightening to learn those very basic tips, which is very, very essential while you are operating upon. I'm sure that many of the orthopedic colleagues from Nepal have taken a lot of information from Dr. Ayyapan. And on behalf of Arthroscopy Society of Nepal, I'd like to thank you very much, and formally would like to invite you to the upcoming, SART conference, which is going to be held in beautiful place of Pokhara, where your Pratendra Vanta is there. Yes. So thank you very much, Ayyapan. Thank you very much.
Thank you so much, sir. Thank you, sir. Bye. Bye, Vivek.
Okay. Thank you so much.
Thank you.
Okay.